So there's been a lot of excitement in the world of prostate cancer by targeting PSMA with therapeutic radionuclides. And you were able to form an interesting study in an earlier than typical disease population. So can you describe the BULLSEYE trial for us?
Yeah, for sure. So many patients, as you know, have prostate cancer, and most of the patients receive surgery or radical prostatectomy or radiotherapy. But unfortunately, a lot of patients have disease recurrence, and that is nowadays often detected by PSMA PET imaging. And patients can then receive SABR or sometimes elective nodal radiotherapy, sometimes also surgery. But sometimes these patients are not eligible to these metastasis-directed treatments anymore. And patients need to start with castration, right, with androgen deprivation therapy. And while it works well, it is often associated with a lot of side effects. And there's fatigue, metabolic syndrome, cardiovascular disease, patients get depressed. And what we noticed already, like using lutetium PSMA in a later stage of the disease, is that it works well, but the side effects are also mild. Patients can tolerate it well. And I think that's the beauty of using it in the earlier phase. Patients can handle it really well. In my view, it is better to tolerate than androgen deprivation therapy. And we're using PSMA PET to diagnose it. Why not also use it as a treatment? And it's not my idea, it is our group's idea that we figured we're going to focus on this particular setting, this earlier stage setting to really treat these patients. And I'm happy to really present these results right now, and I'm happy for all the patients that participated in the trial.
Great. So tell us a little bit about which patients were included and what the treatment was.
So this was an open-label randomized study. Patients were randomized in a 1-to-1 ratio, in total 58 patients. And these patients had high-risk prostate cancer. So they had a very fast PSA doubling time of less than 6 months. And we chose this group because we wanted to include a group that really needs interventions. And these patients were then eligible for up to 4 cycles of 7.4 gigabecquerel lutetium PSMA. So that's the normal dose what we use in the VISION trial, for instance. And versus the standard of care, which was basically watchful waiting before initiating androgen deprivation therapy. And you don't want to initiate that too early, because otherwise patients have only side effects from androgen deprivation therapy. But you want to initiate it early, and that's why we also, androgen deprivation therapy, that's why we included that group with a very fast PSA doubling time in this study. And the primary endpoint was basically androgen deprivation therapy-free survival, and also PSA progression according to the Phoenix criteria, and also toxicity, adverse events, and quality of life.
Okay. So those that received, jumping ahead to the results, those that received the lutetium PSMA 617 did better than those that did not.
Yeah.
Can you describe what the progression-free survival looked like?
Yeah, so the median progression-free survival in the treatment arm was 25 months versus 5 months in the standard of care arm. The PSA response was much better. More than 50% of patients had a more than 90% drop in PSA. Also, 25% of patients had a complete biochemical remission. And at the end of our data cutoff moment, still 60% of the patients were without biochemical recurrence, so still unmeasurable PSA. Toxicity was low, mostly all grade 1, and in the well-known areas, and quality of life remained stable in all patients.
And so the trial used 2 to 4 cycles. How many cycles did they get on average? 4.
So we decided on 2, but if patients still had measurable or avid disease on PSMA PET that was done after 2 cycles, they were eligible for another 2 cycles. And basically what we saw, and if there was no toxicity was low, and we often still saw avid disease, and we continued with 2 more cycles. Patients received mostly 4 cycles. I believe only a few had only 2 cycles.
Okay. Was there another scan after cycle 4?
There was another scan after cycle 4, yeah. And we still need to look into that data of the imaging response.
Okay. So very interesting results. To me, not surprising. You know, generally is at least in this short-term tolerated type of a drug, and better than nothing in a high-risk population. So moving this type of paradigm forward, I don't think that nothing would be the standard of care. So what would your plan to move this type of a treatment in this setting forward?
Yeah, so right now we have stereotactic ablative radiotherapy or salvage radiotherapy at least. I don't see a lot of surgery happening for the metastasis-directed treatments. And if patients have a little bit too much disease, I think it is a beautiful spot for lutetium PSMA, that we can really downgrade the disease again, create a setting that potentially, if they have disease recurrence again, potentially you can use stereotactic ablative radiotherapy again, but you really can keep the disease in an oligometastatic disease and you can postpone your androgen deprivation therapy. And what we noticed that the toxicity was low, so we're also having the hypothesis that potentially if patients have a disease recurrence again, maybe we can re-expose them again to lutetium PSMA, but we need to evaluate long-term toxicity as well. But I think it is a very interesting position for lutetium PSMA. We detect it with PSMA PET. Why not treat it also with PSMA?
The true theranostic type of a paradigm.
Exactly. Yeah. And also, there's also a study going on the PSMA delay castration, and there's also 2 phase 2 trials that's combining stereotactic ablative radiotherapy with lutetium PSMA versus stereotactic ablative radiotherapy, and I think that's also very interesting. Potentially, we need to combine it to really get the best out of both worlds.
Right. Yeah, I think there is some question if lutetium alone would be enough to give an ablative dose, and adding SBRT might increase that.
Exactly.
ADT may also help too, but then there's the ADT toxicity. So
yeah,
it's a decision to make.
Yeah, I'm really looking forward to the PSMA addition data as well, and that's basically looking into that cohort.